BP was 90/50. Respiratory was 34. Saturation was 89% on room air. ABG, which was done, shows below. pH of 7.26, PO2 of 54, PCO2 of 35, bicarb of 6 with base excess of -6, lactate of 4, his hemoglobin was 18, total count of 22,000, creatinine 1.3, LFT total bilirubin of 4.2 and direct bilirubin of 2.6, AST 250, ALT 220. Sanjana, can you tell me what are the abnormalities are there in this patient?
Okay, so this 50-year-old gentleman, vitally he is having tachycardia, tachypnea, and also his saturation is on the lower side. His total count is also elevated, so looks like he is in SIRS response. And BP is also on the lower side, 90/50, and ABG is showing acidosis, and it looks like a mixed metabolic and respiratory acidosis with hyperlactatemia. His creatinine is also elevated, maybe suggestive of acute kidney injury. Liver function test is deranged with elevated total bilirubin, more of direct hyperbilirubinemia. And also this patient has transaminitis.
Okay, very good. But I think ABG is more suggestive of a metabolic acidosis only. There is no respiratory acidosis component in that, right?
Okay. Oh, sorry, sir. I thought PCO2 was 54. Yeah.
Okay. So you should, because in the, especially in the EDIC, no, each answer you should say. Example, I know you said low oxygen. You would have used better word is hypoxemia. And the PO2 was on the lower side. It is 54, right?
54.
Yeah. So it's good. Very well done. So you know these are the abnormalities. Okay. So what are the differentials for this patient?
So differentials, first, since the total count is elevated and the patient is in acidosis, I would think of sepsis. But considering his abdominal symptoms, I would like to think of an acute abdomen versus acute biliary sepsis or any other source of infection in the abdomen, or an acute pancreatitis.
Okay.
And also any UTI or any small bubble ischemia because of the high lactates and abdominal symptoms.
Sanjana, this question will be invariably come pain abdomen, epigastric area pain.
Okay.
So you should generally in the exam, no, you should have a list of differentials.
Yes, sir.
You're telling, but it should come immediately. You can't wait in the exam. Okay, it's acute pancreatitis. You can say peptic ulceritis, cholangitis or cholecystitis, perforation because peptic ulceritis leading perforation, mesenteric ischemia, positive acute coronary syndrome. As I told, also it is radiating to the back. So you should also have a differential of dissection. Okay. Yes. So in the exam, no, see, it's not like everybody knows the answers. In the exam, nobody would have gone without a training. Everybody will know the answer. So all about how we answer the question. In EDIC or IDCCM, you'll have a limited time. Okay, I think IDCCM will have only 15 minutes for the station. Okay, it'll not have more than that. So you can't take more time for the answering. You know it. Yeah, it's not like nobody knows it. Everybody knows it. It's all about organizing. Example, I told last time also, because of ARDS ventilation, you should know tuck, tuck, tuck. These are 5, 6, 7 things are the answers. You should know like that in the exam, okay? Next time, remember it and tell it fast, okay? Okay. What all investigation, any extra investigations you'd like to ask in this patient?
Yes, sir. Only CBC, LFT, and renal function test is done. I would like to ask for an ultrasound of the abdomen, chest X-ray, urine routine analysis, and also I would like to ask for serum electrolytes, chest X-ray, ECG, and echocardiogram. Okay.
Anything else which will specifically say this?
Yes, pancreatitis, serum lipase.
Yes, very good. Okay. Do you know which marker is more sensitive?
Yes, lipase is more sensitive than amylase.
Okay. Okay, fine. So you would like to ask, as you told, invasive abdomen or CT. You did a amylase and lipase. Lipase is found to be elevated. You ask for chest X-ray, CRP, LDH, burn, all those things, triglycerides. Okay. So if this patient, if it comes to triglyceride 1500, what will be your insurance and how will you manage?
This patient is having hypertriglyceridemia, and that would be the trigger for the acute pancreatitis. So this patient has to be started on fibrates,
Okay.
apart from the management for acute pancreatitis.
Okay. Okay. Anything else you would like to do?
Mm.
Anything which will cause increased triglyceride, you will not use it.
Uh,
Okay.
yes, sir.
It can be propofol also, not use
Propofol.
propofol. Regarding diet perspective, no fat diet.
Yes, sir.
Okay. No fat diet, not low, no fat diet.
Low fat. Okay.
No fat diet.
Okay, sir.
Okay. Any other intervention which is found to be beneficial in hypertriglyceridemia?
So
Any
any other?
intervention which might be beneficial in hypertriglyceridemia?
Uh,
Anybody else can? Okay, it's dextrose insulin infusion.
okay, sir.
Okay. Actually, in fact, they say that in patient with triglycerides, the free fatty acids which will cause the harm, that free fatty acids are better controlled with dextrose insulin infusion. Okay.
Okay.
Very good. Few people have answered. And second thing is the plasmapheresis. But nowadays they say that plasmapheresis has a
Mm.
limited role. Okay. So
Yes.
this already we discussed. What is the indication of CT scan in these patients?
So indication of CT scan is when we are not able to come to a conclusive diagnosis, and the cause of the acute abdomen is still a question.
Mhm.
And also, if ultrasound is not able to pick up any diagnosis, and initially in cases of acute pancreatitis, we do not go ahead with a CT. We wait for at least 48 to 72 hours. If we are suspecting any perforation or any mesenteric ischemia, we can go ahead with the
ಆಯ್ತು ನಂದೊಂದು ಕ್ಲಾಸ್ ಶುರುವಾಯ್ತು.
ಸರಿ ಸರಿ
Okay. So very good. As you told, those are the indication. What are the cause of pancreatitis?
So common causes of pancreatitis include alcoholism, hypertriglyceridemia, hypercalcemia, or any gallbladder GB stones,
Mhm.
any trauma to the abdomen, any infections can precipitate pancreatitis.
Very good. Surgery scope is
And post-operative.
yes.
Yes.
Good. So as you told, no, you should be ready with a list. Okay.
Yes.
Okay. Very good. So if it is if we are suspecting a positive biliary pancreatitis in this patient, right?
Yes.
Okay. So how will you work up and how will you manage this patient?
So if we're suspecting a biliary pancreatitis, we have to go ahead with an MRCP or ERCP to look for any obstruction. And ERCP, along with the diagnostic benefit, it also has a therapeutic benefit. And if there is any stenting necessary, that can also be done along with ERCP.
No. So generally they do stenting, or what exactly they do? They generally consider doing sphincterotomy.
Sphincterotomy.
Okay. So as you told, and I wanted to ask us, the alcohol-induced pancreatitis, how much is the dose? You should remember that one.
Mm-hmm.
Okay. Other thing they say is in females who are 40 years are there, 4 Fs are there, no? That you should consider. Along with AST elevation, you should always consider biliary pathology.
Okay.
Okay. So what is the role of as you told, there is a ERCP as a diagnostic and therapeutic role. Can you let me know in which patient it might be more beneficial?
In cases of biliary pancreatitis where there is a CBD obstruction and that is causing back pressure in the pancreas, those patients like gallbladder stone or any yes, these
Yeah,
patients.
actually, they've done a study regarding that. Whichever patient with the gallstone pancreatitis, no, they decide to go ahead with endoscopic sphincterotomy, aspect sphincterotomy, and otherwise they just leave it. Okay. In those studies, they noted that the outcome was not much different in both the groups, except for patients who have a cholangitis or a biliary sepsis or raising bilirubin trend is there. Okay. Just
Okay.
because you have a gallstone in the CBD doesn't warrant per se endoscopic sphincterotomy in this condition. They say that it doesn't warrant. Only in specific subconditions you can do endoscopic sphincterotomy. This is one of the recent trial which was published. Okay, the trial is known as EPIC trial. In that they found that conservative treatment is more than enough for most of the patients unless they have a cholangitis or increasing bilirubin. This is the same thing. I'll not go into that. Uh, so what is the diagnostic criteria for pancreatitis?
So for pancreatitis, there are three criteria. One is clinically, if the patient is having upper abdomen, that is epigastric pain, along with raised enzymes, either lipase or amylase more than 3 times the normal, or if there is any evidence from imaging, either ultrasound or CT. 2 of 3 criteria should be met to diagnose pancreatitis.
Okay, very good. I'll not go into that. Any patient who have isolated lipase elevation, there's no amylase elevation. Which patients are this?
So,
Isolated lipase elevation without increasing the amylase.
yes, sir, we can consider as pancreatitis because
Which
lipase is most
conditions do you see that?
in pancreatitis induced by alcohol binge.
Okay.
Mm. And mm, not sure,
Alcohol
sir.
binge per se, and I'll not say chronic alcohol intake.
Okay. Okay.
Okay. And if they come late, after 3-4 days, they come, amylase lipase might have gone back to normal. In
Okay.
case of acute and chronic pancreatitis also, it will be normal. And in case of hypertriglyceridemia, it is not reliable.
Okay, sir.
Okay. These are the few conditions that might be asked as an MCQ rather than an exam question. Okay.
Yes.
How will you classify pancreatitis?
So pancreatitis can be classified into mild, moderate, and severe. So this is based on multiple scoring systems are available. You can use Atlanta classification or also CT severity index based on imaging.
Okay. Okay. Can you tell me about CT severity index? What is the
Yes.
name of the
So
system?
CT severity index includes 2 components. One will be the Balthazar component involving the pancreas, and the other involving the inflammation. One is regarding the inflammation, and the other will be if there is necrosis or not. So CT severity index 0 score will be for if the pancreas is normal. If there is inflammation of the pancreas, we give a score of 1. 1. And then if there is mild inflammation with minimal fluid around the pancreas, we give 2. And the next will be moderate inflammation with multiple pockets of fluid. And the last will be a large pocket of fluid around the pancreas with inflammation. And necrosis scores will be 0, 2, 4, and 6. 0 will be no necrosis. 2 will be less than 30% necrosis. 4 will be 30 to 50%. And 6 is more than 50% necrosis.
Okay. Are you aware of any modification of this scoring system?
Modified CT severity index.
Yes.
Uh,
They include extra pancreatic complication also. Okay.
Based on whether it is transient or
Okay.
persistent organ
Other thing is
failure.
more than 50%, they consider it as same. It doesn't matter if it is 80% or 50%. They
Okay.
consider it as same. Okay.
Yes.
How do you grade the severity of pancreatitis? Or any markers of severity of pancreatitis you are aware of?
So markers of severity, if the calcium levels, blood glucose levels. So
Okay. Like that, you can go on. What are the markers you are aware of?
Ranson scoring system and Glasgow scoring system.
Okay. Then?
So these include multiple, and Apache 2 scoring system can also be used.
Yes.
So these will be based on lab investigation values at admission and after 48 hours. So these include BUN, LDH values, blood glucose, serum calcium levels, AST and ALT levels. And
okay. You just remember, see, you might have to remember one scoring system. but you have to remember the other markers also. Just in the exam they ask now, you just remember this. Okay, as you said already, Glasgow and this thing. Then Marshall scoring is also there. SOFA score, Apache score, CRP, CT severity index. Okay.
Yes, sir.
Okay, sorry, this I should have written. Any scoring system which can be used within 24 hours?
Apache 2 scoring can be done after 20, okay, within 24 hours.
Hmm.
On admission, BISAP,
Yes, bicep scoring can.
BISAP scoring.
What are the components of bicep scoring?
So BUN, impaired mental status, source response, age more than 65, and pleural effusion.
Okay, very good. Okay. I think we discussed already modified. How will you manage this case of pancreatitis?
Okay. So management will be again ABCD protocol, sir. So airway based on the patient's we need to check if the airway is patent or if the patient's airway is threatened. If needed, secure the airway. Then going into breathing. So we'll have to look for on auscultation, we'll have to examine if to look for any features of ARDS or pleural effusion or any other symptoms, and oxygenation also. If the patient is requiring, we'll have to supplement with oxygenation. And adequate hydration will be required in patients with pancreatitis because there will be a lot of um, extravascular volume loss. And then coming on to nutrition, early nutrition, if the patient is
Hydration,
already.
Can you tell me more about the hydration?
Yes, so in pancreatitis, patients tend to be more dehydrated because of extravascular volume loss and capillary leak. So, and also there will be a lot of pleural effusion and ascites. So, initially, the patient has to be resuscitated sufficiently with enough fluids, and repeatedly we'll have to assess the fluid status and give fluids. Over resuscitation should also be avoided, as that can lead to intra-abdominal hypertension and compartment
Sorry?
syndrome.
I want a specific answer.
Okay. So first, so the fluid you want in the volume of fluid, so
Yeah, volume of fluid. How much you'd like to give?
3 ml per kg per hour.
Okay. Okay, fine. Okay. The recently there's a trial by name waterfall trial. Okay. In that they used moderate fluid resuscitation. Previously they used aggressive. Okay, up to 15, 20, up to 30 ml per kg. Now they are cutting down on the fluids. They have used 10 ml per kg for patients with hypolemia. There are no boluses were given, followed by 1.5 ml per kg per hour.
Okay. So
They
it is
found
not
that
3 ml, so it is 1.5 ml per kg.
yes, yes. Now that things have changed. Okay.
Okay,
So after this waterfall trial, which is published recently in NEGM, things have changed. Previously, we used to do aggressive fluid resuscitation. Actually, we are cut down on the fluids also. Okay. So this is there in most of the textbooks and online literature already. Okay, they're quoting it already. Okay, you can tell in the exams without worrying.
Okay.
Okay. Then how will you? So you said that you don't want to give. See, this 10 ml per kg or 1.5 ml per kg is not standard for everybody, no? So how will you titrate your goal or your fluids?
So we can look at the patient's volume status by clinical examination. We can look at the patient's tongue and urine output, capillary refill time, the blood pressure, and also ultrasound we can use to check the IVC of the patient.
Okay. Any lab markers which will be beneficial in this patient?
Hematocrit.
PC.
Yes. Hematocrit or PCV, then?
And
Bun also, sir.
Yes,
yeah,
very good.
one.
One answer. So you should always use the word. I'll start with the fluid of 10 ml per kg followed by 1.5 ml per kg per hour. I'll do a goal-directed fluid management, targeting my fluids towards the clinical parameters of this and lab parameters of these things. Okay.
Okay. Okay.
Which fluid you would like to use? Sorry. I don't know. It's not working. Some problem is there. Which fluid you would like to use?
So Ringalactin.
Yes. Why? Why not?
So since we will be administering a large volume of fluid, normal saline can cause hyperchloremia.
Then?
Also, it can lead to hyperchloremic acidosis.
Yes. So it is thought that this acidosis might activate the proenzymes, further causing more such response. Okay. So when they
Yes.
noted that RL had a better outcome, less hospital stay, less admission, less necrosis, less CRP level, and less organ failure. Okay. So regarding nutrition, how will you manage?
Early nutrition is very essential in pancreatitis since there'll be increased breakdown of proteins and fat. So if the patient is tolerating orally, it is better
Sanjana,
to.
just a short.
Hmm.
You think it is due to that early nutrition is essential?
So one thing, it is a catabolic state,
Yeah.
and also if there is no nutrition, whatever enzymes are being produced by the pancreas might
It is essential to maintain the gut integrity. Okay.
get in. Yeah.
Okay. If you don't feed them, it invariably there will be gut translocation.
Hmm.
Okay. Okay. Go ahead. Is very important to feed. You want.
Yes. And if the patient is tolerating orally, we can go ahead with enteral feeding.
Okay. Very good.
Yeah. So early enteral nutrition is
Okay.
advisable.
Any specific type of feed you would like to consider in these kind of patients?
Specific type of feeds is say like you're asking about the like amino acids, simple feeds.
Maybe elemental feeds have any role, or
Yeah.
fat or protein adjustment, anything is required in these kind of patients.
Yes, elemental feeds are essential.
Okay. Okay. Elemental feeds have not shown any benefit. Okay. You can
Okay.
consider giving low fat diet. One thing they recommend is medium chain fatty acids.
Okay. So elemental feeds are not recommended.
Not recommended.
Okay.
Okay. As you know already. So the recent one last trial which has come is paddy trial. They found that early feeding is associated a lower length of hospital stay. Okay. In mild as well as the moderate pancreatitis also, they found it's beneficial to start as early as possible. I think NS versus NJ feed, you are aware of it already, but tell me once. NJ
Uh,
versus NG.
so nasogastric, there is no difference in mortality or any advantage of NJ feeds over NG feeds.
Okay.
And yeah, we can go ahead with NG tube feeding.
Okay, fine. Okay. So other thing they have noted that when you use medium chain triglyceride, the patient's tolerated feeds better. Okay. And there's no benefit of elemental feeds per se or polymeric feeds. There's one thing actually I found in a literature when I was going through something known as rhubarb. It is not mentioned much in our literature. It is found to be associated with improved gut function. Even if you don't mention, it's okay. Maybe somewhere some remote MCQ might get it. That's it. Okay. So how will you manage the pain?
So pain has to be again adequate analgesia with oral, or if oral is tolerated, oral or IV analgesics. NSAIDs can be avoided. Other methods can be epidural analgesia and also opioids like fentanyl infusion or a patch.
Okay. What is the concern with using opioids?
Opioids concern will be if patients are requiring high doses of opioids, the patient's peristalsis and gut motility might be affected, resulting in.
Yes. Also, it will cause the constriction of sphincter of the theoretical possibility. They feel that out of all the analgesics, fentanyl is kind of safer. Okay. So, as you told you that there's recently one Chinese study they have published that epidural analgesia has got a mortality benefit. Chinese study has published recently, 2022 it has come. You can check in detail, but maybe in the exam they might ask that role of epidural analgesia. It's good that you mentioned here, so that in the exam, even if they add that component, you should not miss it.
Yes.
Okay. Recently, Chinese studies have shown that there's a mortality benefit. Antibiotics role?
No need to administer antibiotics in.
Okay. Which even if you want to consider if they suspect some infection, what antibiotics you would like to consider?
So carbapenem and imipenem is
So if initially infection, if they consider, no, it will be not be pancreatic infection. It will be extra pancreatic infection generally, something like cholangitis. Okay.
okay.
That time you will try to avoid the antibiotics which penetrate the pancreas.
Okay.
Okay. Which antibiotics penetrate the pancreas?
So carbapenem
Yes.
and mm,
Please tell me.
sorry,
Carbapenem?
sir, I
Or
didn't
other antibiotics other than carbapenem?
for pancreatic infection.
Yeah.
So carbapenems, fluoroquinolones.
Yes.
Mm.
Anybody else? Hydroxychloroquine also is considered. Okay. Metronidazole and fluconazole. Okay. These are the antibiotics which have got a better penetration to the pancreas. I think this question generally they ask in the exam. Okay. So role of probiotics. Recently, some study have come up in 2022. Okay. I'll just tell it off. They found that they help in better tolerating the feeds. Then role of procalcitonin.
So the role of procalcitonin is an inflammatory marker, so it might be elevated in pancreatitis. It can be used to de-escalate or stop antibiotics in case it was started suspecting an infection.
Okay. Especially in procalcitonin, any studies, anything you are aware of? What is the role? So in procalcitonin, no, in pancreatitis, they have done a study where they measure procalcitonin at 0, 4, and 7 days. They start antibiotics only if procalcitonin is more than 1, or stopped it if it is less than 1. They found that antibiotic prescription was much lower if you used a procalcitonin guided. It didn't change the mortality or anything, but just that less prescription of antibiotics if you're using procalcitonin.
Okay.
Okay. So we'll go to next. Okay. Patient was managed conservatively. On day 7, patient condition started worsening with worsening SIRS response. How will you approach this patient?
So again, I will go ahead with an ABCD approach, sir.
Okay.
So again, airway, I will secure the airway if it is threatened. Coming on to breathing, I would like to look for any chest infections or any ARDS and worsening of the effusion. I'll also like to go get an X-ray done.
Okay.
And yeah, worsening SIRS response, tachycardia, and hypotension. If it is there, I would like to check the patient's volume status and administer fluids as well. And I would like to send cultures and urine protein examination to look for any source of infection.
Okay. What are your differentials?
So differentials here would be any source of sepsis, ARDS, necrotizing pancreatitis.
Yes, very good. It's very important to mention necrotizing pancreatitis. Okay. Then
compartment syndrome.
yes, very good. Okay. In this patient, my differentials will be mainly necrotizing pancreatitis, any infection, hemorrhage, or perforation. As you told, already imaging, you should include a CT scan also.
Yes.
Okay. This is a CCT of the patient. Same patient it was done. What is it showing?
Sir, it is showing necrosis of the pancreas along with fluid collection around.
Okay. Okay,
And
very good.
also air flu.
Okay, that is okay. That is just air fluid level. You can see that. So basically, you are seeing two things. There is a necrosis of the pancreas. There is a peripancreatic fluid collection.
Fluid collection.
Let me mention these two things, very important. Okay, how will you manage now?
So there is necrosis of the pancreas along with fluid collection. So all basics in investigations, as mentioned, has to be sent. Complete blood count. I would like to look at the electrolyte levels. Sent for cultures, renal function, liver function tests, and also get an ultrasound to look for any biliary sepsis if it is worsening. and send procalcitonin as well and start the patient empirically on antibiotics. And if possible, also percutaneous drainage or an FNA of the pancreatic fluid and send that as well for analysis.
Okay. How many of you agree with that to do an FNA? Okay. FNAC generally, Sanjana, is an outdated practice now.
Okay.
Okay.
Ultrasound. Okay.
Yes. Now what they're thinking is even if we suspect infection, start with antibiotics.
Antibiotic.
If we try to meddle anything with that necrosis, already such a bad damage, necrotic collection, instead of draining, we are going to introduce more infections.
Okay.
Okay. Now the suggestion is conservative as much as possible. Okay. You want to
Yes.
consider escalation of antibiotics, consider role of intervention is kind of considered not controversial, it is of no use. There have been a lot of studies which are done in this aspect. I think you are aware of step-up approach. Basically, they say that initially, if required, you do a percutaneous drainage followed by step-up surgery. Okay, that was the Panther trial. So then there are multiple trials have come. I'll just mention it. You go read it. Now the recent trial is tension trial. Anta. You initially do a percutaneous drainage. No, later they used to do surgical treatment. In tension trial, they found that endoscopic is better tolerated. They have better outcomes compared to surgical drainage. Okay. So recently they have done a trial with early versus late drainage. If there is a necrotic collection is there, one they drained early within 24 days, second late drainage. They found that they are better managed if they did a conservative treatment and almost 40% of the people didn't require any drainage only if you do it late.
Okay.
Okay. And one more study recently published in Gut Disease, they noted that there's high risk of secondary infections if drainage is done. As you see here, infection rate of 73% if they do a drainage. So according to this, at this point of time, my take will be, okay, conservative as much as possible. No role of FNAC. FNAC is completely out of the question.
Okay.
Okay, if you want to do drainage, you can do percutaneously, followed by endoscopic approach. Surgery, avoid as much as possible. If possible, avoid drainage also as much as possible. Even if necrosis is there, necrotic collection is there, antibiotic is the line of treatment. Do give antibiotic rather than draining it.
Okay.
Okay. So can you list the complication, local and systemic?
Yes, sir. So in pancreatitis, localized complications can be pancreatic hemorrhage, necrotizing pancreatitis, peripancreatic fluid collection with pseudocyst formation, and localized. These will be localized. Other complications can be sepsis and shock, intra-abdominal hypertension or abdominal compartment syndrome, acute kidney injury with acute kidney injury and ARDS and
Okay.
circulatory shock.
Okay. Okay. You can just list it. Okay. You remember this and list it. In the exam, just remember and tell it fast. That's it. So this patient continued with managed with fluids and antibiotic. You noted that later that patient abdomen was quite tense and distended. Air entry is significantly reduced at both lung bases. Urine output is at 10 ml per hour since last 6 hours. ABG shows acidemia, hypercapnia, and hypoxemia with PF ratio of 77. So how will you approach? What is your differentials?
Okay. So here PF ratio is 77. So and also acidosis with hypercapnia. I would like to think of ARDS from respiratory point of view, and also the abdomen is distended and tense, and also the urine output has reduced the last 6 hours. So I would like to think of an abdominal compartment syndrome.
Yes, very good. So your differentials will be abdominal compartment syndrome. It can be sepsis. It can be mesenteric ischemia, sometimes portal vein thrombosis and cause fasciitis. These are your differentials at this point of time.
Yes.
Okay. So can you define abdominal compartment syndrome?
Yes, sir. Abdominal compartment syndrome is when the intra-abdominal pressure is more than 20 millimeters of mercury. And intra-abdominal hypertension can be divided into different grades. If it is
What
more
is
than
intra-abdominal hypertension?
more than 12.
Okay. What is abdominal compartment syndrome? Can you tell me again? More than 20
More than 20
with
with any
organ.
organ failure.
Yes. Okay. Go ahead. How
Yeah,
will you
so
classify?
in intra-abdominal hypertension, 12 to 15 will be grade 1, grade 2 will be 15 to 20, 20, and then 20 to 25 will be 3, and more than 25 will be 4.
Okay. Okay, fine. What are the consequences of abdominal compartment syndrome?
Can lead to organ failure, sir, acute kidney injury, renal involvement, and also the perfusion to the gut will reduce, leading to bowel complications, eccentric ischemia, ileus,
Mm.
and
Yeah. You tell all the organs, no? What all the organs are there in the body? Start listing.
yeah.
Sanjana,
Yes, sir.
list the complication according with each organs.
Okay. Each okay. Kidney, acute kidney injury and renal failure, bowel ischemia, ileus,
Mm.
and then spleen and liver involvement can cause hepatic or splenic infarcts. The blood supply.
Can it cause hemodynamic compromise?
Yes, sir. It can cause shock.
Can it cause
Can
respiratory
lead
compromise?
to ARDS, respiratory compromise. Because it can also affect the CNS. The patient can go into encephalopathy or altered sensorium,
Okay.
circulatory
So
shock.
you should just list the organs which are there. Okay, it can cause respiratory complaints. How will you manage if there is a high abdominal compartment syndrome with the respiratory compromise? How will you manage?
So we'll have to sedate and paralyze the patient.
Okay.
Also,
No,
we'll have
from the respiratory perspective, you mentioned.
from respiratory perspective. So
Yes, yes. You sedate and paralyze. Anything else can be done?
we can increase the PEEP.
Yes, you can increase the PEEP. Generally, they say half of the PEEP can increase. Okay. In the example, if abdominal compartment syndrome is 20, you can increase the PEEP by 10, something like that. Or you can use the transpulmonary pressure guided PEEP adjustment.
Yes, sir.
Okay. So there is a hypertension, there is a renal failure, there is a mesenteric ischemia, portal vein thrombosis, ileus. So you can just list the organs which are there and what all problems it can cause. Okay.
Okay, sir.
How is abdominal compartment syndrome pressure measured?
So intravesical catheter, with the help of the intravesical catheter. So the patient has to be sedated and paralyzed, and the abdominal muscles have to be relaxed. The patient should be in a supine position. And after instilling 25 ml of saline, and the pressure is measured after zeroing at the level of the mid-axillary line and iliac crest.
Okay. Patient should be supine. It should be paralyzed. Okay. So how will you manage abdominal compartment syndrome?
Abdominal compartment syndrome. So first will be fluid management.
Okay.
Fluid restriction, and also sedate, paralyze the patient.
Yeah.
Ventilatory support according to PEEP, as you had mentioned, sir. And also, we'll have to constantly keep monitoring the urine output, and the patient might require renal replacement therapy. And if the abdominal compartment syndrome is still persisting, the patient might require decompression, adequate analgesia.
Okay. Okay. So one thing is they should keep this patient's NPO. Okay. And NG aspiration should be continuous drainage might be there. Okay. Sometimes you might have to remove fluid by using CRRT. Okay. Or RRT, whatever. So that's good. So patient was diagnosed with abdominal compartment syndrome. He has kept NPO, needed vasopressor support and CRRT. On day 12, they decided that they'll initiate TPN. Okay. On day 15, patient was noted to have a ventricular tachycardia, which was reverted by cardioversion. What are your differentials for this patient?
Okay. So differentials first would be refeeding syndrome. And dyselectrolytemia that would have led to the VTAC.
Hmm.
And other differentials would be sepsis with septic shock
Yes.
or acute coronary syndrome.
Yes. Very good. Okay. So your
Yes.
differentials were dyserythroid anemia, most likely due to refeeding syndrome is the most common differential. I will investigate this patient.
So I would like to check all the electrolytes, including calcium, magnesium, and phosphorus in this patient.
Okay. Calcium, magnesium, and phosphorus, or something else, one more. Which electrolyte is more important?
Phosphorus,
Yes. Phosphorus, magnesium, and potassium.
potassium.
Yes. Okay. 1 minute.
Yes.
Okay. How will you avoid or treat refeeding syndrome?
So patients who've been chronically deprived of nutrition, we will have to start feeding them slowly.
Hmm.
And before starting the feeds, we will have to correct all the electrolyte disturbances and then
Okay.
start feeding with 50% of the caloric requirement and then step up gradually.
Okay. Always correct the electrolyte disturbance first. Okay. Whenever you're stepping up the feed, make sure that those electrolytes are monitored and corrected. Don't increase the feed without correcting the electrolyte disturbances.
Yes.
Okay. That's it. Very good. So that's it, Sanjana. You did
Thank
very well. Okay. And this is a pretty straightforward scenario you get in the
Yes.
exam, especially with respect to pancreatitis. There's no
Yes.
answers in this. Okay.
Yes.
So any feedback, anything you want to ask?
Mm,
That gallbladder ERCP role they might ask. I don't
okay.
know how many examiners will accept not doing a percutaneous drainage. In the exam, you can still answer percutaneous
Uh,
drainage.
so we can just step up, escalate the antibiotics without doing a drainage and sending the fluid for analysis, sir.
Yes, FNAC there is no role. FNAC is
Okay.
completely no.
Ultrasound guided drainage. Okay.
Percutaneous drainage may
Hmm.
still have a role, but
Hmm.
that's what recent studies are coming. Even you may not require to do a percutaneous drainage also.
Okay.
Okay. Try to be conservative as much as possible. But in the exam, please mention percutaneous drainage. Till it will go out of a routine practice. You have to mention percutaneous drainage.
Okay, sir.
Okay. I think one more complication they might build up during this is AKI. They might ask question regarding the
Hmm.
AKI. How will you initiate CRRT? How will you manage all those things they'll ask.
Yes,
AKI
sir.
complication. One more complication they might go is generally some of the patients will develop a bleeding.
Hmm.
As you developed a scenario of sepsis, no,
Hmm.
for something, patient became developed hypertensive tachycardia and all. In that,
Okay.
patient would have developed tachycardia, then you will do an imaging, most likely CECT and all. There they noted that. It might be there is a bleeding when they did a CECT. How will you manage? Okay. There,
Hmm.
certainly, they nowadays they do intervention and manage rather than doing a surgery. You'll
Hmm.
say that I'll take a surgical opinion and interventional radiology.
Interventional radiology. Okay.
Yeah. Okay, that is one of the scenarios they might develop during the management.
Yes, sir.
Okay. So these are the scenarios generally which with respect to pancreatitis you'll get. Okay. Anything else? Any questions from anybody else? Okay. Thank you, everyone. You can for feedback or any queries, you can ask me directly. Okay. Thank you.
Thank you, sir.